Hi, this is Bridget Sharon Brown with Summit Central. This year, the Summit at Snoqualmie Ski Patrol's Outdoor Emergency Care Committee has chosen the topic of sick, not sick for the 2012-2013 Continuing Medical Education Program. Sick, not sick isn't anything new. It's been used by King County and other EMS systems for many years with excellent results. In fact, most of this material comes right out of the King County EMS online training program. And it really doesn't ask us as patrollers to learn anything new. What it does is take the assessment tools in our toolbox and helps us to streamline those to make a rapid decision whether or not our patient is critical or not. Sick, not sick is actually something we've been doing for a long time without really realizing it. Let's give you an example. You're in the main lodge and all of a sudden a guest slumps over. He's clutching his chest, and as you approach, you notice that he's pale and sweating, and he tells you that he's got chest pains radiating into his jaw and his arms. Stop right there. What are you already thinking? Uh-oh, this patient may be having a heart attack. Do you know that for sure? No, but you're going to go with it because chances are that he is. And you're going to get ALS rolling, you're going to call for equipment, and you're going to move quickly to get this patient to definitive care and to make sure that if he does go into a full arrest, you've got the defibrillator and help there. That's a rapid assessment determining that this patient is in trouble, that he's sick, and you did it in less than 60 seconds. And that's what Sick Not Sick is all about. This video is going to take you about 30 minutes to watch, and at the end we'll include about half a dozen paper scenarios. We're going to show you a picture, give you some basic information, and ask you to make a rapid determination of sick or not sick. We thank you for your attention and we appreciate your time because we know how valuable it is. So why did we choose Sick Not Sick? Well, Sick Not Sick allows us to do a rapid medical assessment like that guy we just talked about in the lodge, and utilizing the same tools, and just as rapidly we can do a rapid trauma assessment. Sick Not Sick puts all of us on the same page. So that means when you're on a scene and you radio down to base, hey, I've got a sick patient, base knows exactly what you mean, as do any incoming patrollers who are going to be assisting you. And when base calls down to dispatch and lets them know that we have a sick patient, dispatch knows what that means, as do incoming EMTs and medics. Sick Not Sick has been tested and it's been proven to improve patient outcomes, and hey, what is more important than that? And the really cool thing about Sick Not Sick, you can do it in less than 60 seconds without even touching your patient, like that guy in the lodge we just talked about. So let's start out by looking at some basic vocabulary. You probably know most of these terms already. One of the first criteria we use for Sick Not Sick is an index of suspicion. That's that gut feeling. You know that feeling when you approach a patient and just by looking at them you can tell that something's not right? You know what studies have found? That when rescuers have that feeling, they're probably dead on. So you go with it. The next is mechanism of injury. Yep, we got that from OEC 5 as well. Basically, it's what happened. And it's not just for a trauma patient, what happened, but how severe was what happened. How likely is that mechanism to have caused a serious injury? Along with mechanism, we go with that nature of illness. What type of medical condition does this patient have that could be causing these signs or symptoms? And we're going to be talking about sick and not sick. So let's define sick. Sick in this context does not mean ill, like having the flu or a cold. Sick means that at this moment, that patient appears to be physiologically unstable. That means that patient has a risk of going into shock. We're going to use 5 criteria to make that determination. I'm going to talk about those in just a minute. Of course, the antithesis to sick is not sick, which means right at this moment, that patient appears to be physiologically stable. There are no signs to tell you there's a chance this patient could be going into shock. Some of the criteria we're going to be using to make the determination of sick, not sick, including our index of suspicion, our mechanism of injury, and our nature of illness, include skin signs. We know what those are. You look at a patient. What you want to see is someone who's warm, pink, and dry. And if they're clammy, diaphoretic, that's a patient who's potentially sick. We're also going to use RPM. Recognize that? That comes right out of OEC 5, Chapter 4, triage. When we're doing a triage assessment at a multi-casualty incident, we use respiration, pulse, and mental state to make a quick determination whether our patient is red, yellow, or green. Well, Sick Not Sick uses the same criteria, using respiration, pulse, and mental state to determine sick, not sick in our patient's status. RD, that stands for respiratory distress, that A in the ABCs. Any sign of respiratory distress is an indicator of a sick patient. And of course, we're making a decision to move definitively towards ALS or BLS care, advanced or basic life support. Let's put these words to use. We already talked about sick as meaning an appearance, not a definite definition or diagnosis of physiologic instability, but a patient who at this moment appears to be physiologically unstable. You can also reclassify sick as critical, urgent, unstable, or requiring ALS evaluation and rapid transport in that direction. The criteria we use to make a determination of sick, not sick, and think back to approaching that patient in the lodge, would be respiration. Any sign of inadequate respiration classifies a patient as sick. If you have a patient with a weak pulse or visible signs of poor circulation, that patient can be deemed as sick. We're going to go into more details on these in just a second. The third is a decreased mental state. Any altered mental state is a sick patient. Skin signs. Any poor skin signs, anything less than warm, pink, and dry, can be classified as poor skin signs and a sick patient. And body position. We're going to talk about body position. It relates more so to your nature of illness situations, but can also apply to trauma patients. Inappropriate body position can be indicative of a sick patient. Inadequate respiration, weak or a weak pulse or visible signs of poor circulation, altered mental state, poor skin signs, and appropriate body position, along with a mechanism, nature of illness, or an index of suspicion, are your criteria for making a sick determination. So let's look at these in a little bit more detail. All right, let's go to a situation where you're called onto the slope for a patient who's been sitting there. First thing, of course, we're going to do is look at the big picture. Is the scene safe? And we're going to take care of our BSI. Then you're going to approach the patient. And think about as we're approaching a patient, the first thing we probably notice is what body position is that patient in. Is that patient sitting or standing? Are they prone or supine? Are they slumped? Or maybe they're tripoding, leaning forward on their hands and trying hard to breathe and pull air in. Maybe you notice that this patient is slumped, and when they try to sit up, they grow pale. Or maybe they tell you that they're feeling faint, or their vision or hearing is dimming out. That's a sign of syncope, of faintness, also known as a postural change to vital signs. As we approach that patient, we're going to note that body position, and the next thing you're going to do is you're going to take a look to see if you see any indicators of respiratory distress. Of course, with body position, you're going to notice whether or not that patient is tripoding or appears to be working hard to breathe. Do you see any nasal flaring or maybe retractions of intercostal muscles? And how about if you ask that patient a question? Can that patient speak comfortably, a full sentence, or can they only answer you in 1 or 2 words? What you can also do is listen for audible sounds of breathing from a distance. Basically, as human beings, we can't hear each other breathe unless we get really close. And sleeping aside, there are basically 3 times when we can hear people breathe from a distance. The first is when we're exercising, but in healthy individuals, as soon as you stop, that breathing should quiet down quickly and go back to an inaudible, a normal rate. The second time you can hear us breathe is when we're having sex, which I hope we're not seeing on the ski slope. And the third is if we're in some kind of trouble. So if you approach a patient and you can hear breathing from a distance, maybe they're wheezing, that's a sign of a sick patient. The next thing you look at is what's that patient's mental state? Is there any indication of a decreased level of consciousness? Are they confused or feeling faint A quick assessment can be done using the ANO or the AVPU scales. ANO, of course, stands for alert and oriented. And what we want that patient to be is alert and oriented to 4 things: person, place, time, and event. That means who I am, where I am, what day or time it is, and what happened. If a patient can't answer 4 out of those 4, then you classify that patient as having an altered mental state, and that patient can be classified as sick. Or you can use AVPU. A stands for alert and oriented, or V means they're verbally responsive only. So you tap them and try to get them to talk to you, and only then do they open their eyes and look at you. Or pain responsive. All you can do is elicit a response to pain. Or maybe that patient's completely unconscious, unresponsive. So any decrease in that mental state is an indicator of a sick patient. Now we're also going to look for those skin signs. Remember, the skin signs can also tell us how well that patient is breathing. If that patient is pale and diaphoretic, then what's probably happening is that their blood is shunning inward to the core and is no longer perfusing well on the periphery. So that patient's going to be growing pale. And you also may be aware at that point that that patient probably doesn't have good pulse, good circulation. So to find a pulse visibly, we just look at the patient's color or position, or if that patient tells us they feel weak if they try to sit up. That's a sign that the patient is not perfusing well. Remember that anytime we approach an unconscious patient, we're going to go for a carotid pulse. With a conscious sick patient, we're going to go for a radial pulse. And that's part of the hands-on part of sick, not sick. We've all done this. Let's say you get to a patient and maybe they're not looking quite right, and you go to take a radial pulse and you can't find it. So you know what we do? We say, there's something wrong with me. I can't find that pulse. Nope, it's not you. It's the patient. If a potentially sick patient has an absent or weak radial pulse and you can't find it, that's an indicator that peripheral perfusion isn't good and that patient doesn't have a radial pulse. That's an indicator of a sick patient. If you can find that pulse, you ask yourself, is it weak or thready? Also an indication that that patient is sick. Of course, we have to touch a patient to determine the temperature. How does that skin feel? Is it cold and clammy? Remember, skin signs are indicative of a sick patient. Postural vitals. Postural vitals really relate more to your sick patient per nature of illness. We don't want to ask a patient who has suffered a traumatic event, a trauma patient, from moving position, from lying to sitting to standing. But a trauma patient may also tell you that if they try to go from slouch to sitting upright more, they feel faint. That again is a postural indicator. That means their blood pressure is dropping and they're not perfusing well. With a medical patient, you could try actually taking postural vitals. Remember, you do that by having the patient lie down, take a blood pressure and a pulse, record it, and then have the patient sit up, preferably dangling their feet, and make sure that that patient is in a position where they could fall. You wait a full minute and take that blood pressure and the pulse again. If at any moment the patient tells you they feel like they're going to faint, you classify that as a positive postural indicator. Or you note the difference between the first BP and the first pulse. And if there's a drop of 20 points or more in the systolic blood pressure or an increase of 20 points or more in the pulse, that's a positive postural and an indicator of a sick patient. If the patient shows no sign of postural change and the blood pressure and pulse stay the same or close to the same, then you can go ahead and have them stand, unless it's contraindicated. Again, if that patient tells you they feel like they're going to faint, that's a positive postural, and have that patient lie down again. If the patient's color is good and they don't feel faint, wait 60 seconds, making sure your patient can't fall. Once again, take that blood pressure and pulse, and again, look for that 20-point drop in BP and that 20-point increase in pulse. That's a positive postural and an indication for a sick patient. Okay, so now we've gone through indicators for a sick patient. What about that not sick patient? Not sick does not mean that your patient is not ill, not injured, and doesn't need your care. What not sick means is that at this moment, this patient, once again, shows signs of physiologic stability, and you don't need to make a diagnosis of that. Basically, the same criteria are used, but there's no negative indicators. So this patient will present with adequate respiration, They can speak full sentences, they're not tripoding, and they're not showing evidence of working hard to breathe. WOB means work breathing. They've got an adequate pulse, both by a visual on perfusion, and you can go in there and find a strong radial pulse. Likewise, this patient is alert and oriented and doesn't score any deficits on the ANO or AVPU scale. They're not confused, and they're not feeling like they're going to faint. Their skin color is good, they're warm, pink, and dry, and they're showing signs of adequate perfusion. And their body position is good. They're upright, they're not slouched, and they're not slumped, because sick patients are slouched and slumped. And there's no evidence of dizziness if they change their position. This patient may be injured, but they're not critical and they're stable. You can go on with a full evaluation, and probably they'll need no more than BLS care. Remember that you should be able to determine 4 out of 5 of sick, not sick, just approaching the patient on the scene. Do you remember what those 4 are? If you said body position coupled with a mechanism or a nature of illness, respiration, mental state and skin signs, you got it. It's important to note that sick, not sick is a dynamic process. That means your assessment of sick, not sick is actually ongoing, and you want to reassess your patient every 5 to 10 minutes because your status could change. That little triangle, that means change. So let's say you approach a scene, you do your assessment, and after 60 seconds, you can't decide, is this patient sick or not sick? What you're going to do is classify that patient as not sick. You're going to initiate your care, reassess in 5 or 10 minutes, and see if your patient still stays not sick. So let's try this example. You've been called to a scene where somebody fell in the train park and now they've got a fractured clavicle. Patient, on appearance, is not sick by all the criteria. So you're splinting this patient, getting ready to transport them, and you look at the patient and suddenly realize that his color has gone really pale. This patient has, per sick, not sick, now gone to a sick category. Notify base and be moving quickly, and initiate quickly whatever care you need, such as administering oxygen, slinging, swathing, splinting, and getting that patient down. Likewise, if you have a patient who presents, let's say, with chest discomfort and they're pale and they're kind of slouched, you might classify that patient, or you would classify that patient immediately as sick. So let's say they take nitro. You help them with their nitroglycerin and their color perks back up, the pain goes away, they're sitting upright and they're feeling better. You can reclassify this sick patient as not sick. So sick, not sick is a dynamic process, but go with what you've got right at this moment. Remember that sick, not sick is designed to keep you from making delays in decision making. It keeps us from spinning our wheels and requires us to act on that first impression rather than trying to interpret what could be a really confusing set of signs or symptoms. So you're not sitting there going, gosh, does this patient have a concussion or don't they? Could this actually be a belly bleed or isn't it? You're not going by a potential diagnosis. You're going by signs or symptoms you see and making a rapid decision that this patient is stable or not sick or sick. Remember that sick means that they may need immediate BLS care and they need ALS evaluation. Not sick patients can stay at a BLS level of care. They don't need immediate ALS evaluation, and you can take a little more time. Your sick patient should be seen as critical, urgent, and unstable, and your not sick patient should be seen as not critical, not urgent, and stable. You can take a little more time. We're going to use the criteria of a significant mechanism, nature of illness, or an index of suspicion, that gut feeling, signs of respiratory distress, altered mental state, poor skin signs like pallor or diaphoresis, and an inappropriate body position to determine sick. Remember that sick, not sick rapidly assesses the ABCs, and stalling or delaying decisions on scene equates with poor patient care and results in poor patient outcomes. Sick, not sick is designed to keep us moving. There's a few key mistakes that especially people who just start out using sick, not sick can make, and these are to delay your decision. Again, if you don't know within 60 seconds, classify that patient as not sick and keep going. The other mistake is to fail to respond to new information. Like that kid with the collarbone who went from being not sick to suddenly going pale and diaphoretic. You need to respond to that new information, reclassify that patient, and move more quickly. The other mistake, and we all do it, we get tunnel vision. We get focused on that gnarly angulated fracture, or that grossly bleeding wound, or that femur fracture, and we forget to look at the whole picture, because sick, not sick, asks us to keep the whole picture in mind. Another mistake is poor documentation. I know we're on the hill and documentation is tough, but have BASE as your ally. Call in your information, give repeated short reports and update them, and have BASE scribe for you. You can take that information later and add it to your SOAP and incident report form. The other key mistake is ignoring your gut, ignoring that index of suspicion, and ignoring a significant mechanism or a nature of illness that could indicate this patient has a severe belly bleed or is having a heart attack, for example. Let's use the example of a 10-year-old girl who falls 25 feet out of the chairlift onto compact snow. As you approach and do a rapid assessment, sick, not sick, you determine that by everything you see, she's not sick, she's stable. But you're going to classify this girl as sick. Why? Because that's a significant mechanism, and it's unlikely that somebody could fall 25 feet out of a chairlift and land on hard pack and not be injured. And don't ever let anybody talk you into down classifying a patient as not sick when they've suffered a significant mechanism of injury. So you might ask yourself, well, what if I make the wrong choice? Well, that's the beauty of sick, not sick. It allows you to make a decision based on the information you have right at this moment. And you can't go wrong by treating a patient based on what you clinically see. So if your patient is pale and sweaty and you classify them as not sick, you know that you need to administer oxygen, do whatever else you need to do to treat any kind of life threat, and to move quickly, to do what we know how to do as OEC technicians. And it's okay to start that BLS level treatment without knowing for sure what's going on with your patient. You don't need to know for sure that that's a concussion or that's a belly bleed. You're going by signs and symptoms. In review, sick, not sick takes about 60 seconds, usually a lot less. And 4 out of 5 of the components can usually be determined on approach without even touching the patient. The most important thing to remember is that for sick, not sick, they don't need to score negatives on all those components. If even one comes up in a sick criteria, you classify that patient as sick. Just one of those components. Those components include the mechanism, the nature of illness, your index of suspicion, and your chief complaint. Remember, always address the patient's chief complaint. So if they tell you, my gut hurts, you're going to take a look and you're going to palpate. Then you're going to go into the sick, not sick assessment mode of checking the respiration, the pulse, the mental state, the body position, and those skin signs. And remember, those can be determined from a distance. Let's try it. I think you're going to find this is actually pretty easy. Take a look at this patient. You've been called into the lift operator's dorm because one of the guys is ill. As you step into the room, you see the patient sitting comfortably in bed. You can't hear him breathing from a distance. His skin is warm, a little flushed, and it's dry. He's alert and oriented, 4 out of 4, and he tells you, man, I feel awful. Is this patient sick or not sick? You got it. He may be ill with the flu, but he's not sick. And you determine that by the fact that he's sitting comfortably, you can't hear him breathe, he doesn't have any indicator that he's struggling to breathe. He's warm, flushed, and dry, and he's alert and oriented. Let's try another. You're called into one of the lodges because a little girl is sick. On approach, you hear audible wheezing, and she's coughing weakly. She's pale and is slouched back on pillows. As you approach, she tries to sit up, and you notice that her color gets even worse. Her mom tells you that she had a fever last night, and for the past hour is having trouble breathing. She has no history of asthma. Based just on what you see, is this little girl sick or not sick? Right, she's sick. Bet you caught that right away. It's that audible wheezing, her pallor, the fact that she has an inappropriate body position, and that when she tries to sit up, there's evidence of a postural drop. Okay, doing well. Let's try another. You approach the scene and this is what you see, a mangled car. As you approach the vehicle, the police officer tells you that all the passengers in the car are dead. You find the driver sitting upright on the curb. He walked over to it. He's cradling his head in his hands and he appears uninjured. His skin is warm, pink, and dry, and there's no evidence of respiratory distress. He's alert and oriented, 4 out of 4, and he tells you nothing hurts. Is this patient sick or not sick? Remember that mechanism? He was in a car in which the accident was severe enough to kill everybody in it except him. His chances of not being injured are pretty slim, and even though at this moment he presents as not sick, physiologically, we're going to call him sick based purely on that mechanism. Remember, they only have to meet one criteria. All right, how about this lady? You approach the scene, and this is what you see. The patient's unconscious, which you determine by tapping her on the shoulder, and she doesn't respond. You notice that her skin is warm, pink, and dry. You notice that no airbags deployed, and she wasn't wearing a seatbelt. Witnesses tell you she hit a tree at about 35 miles an hour. There's no evidence of respiratory distress, and you can find a strong radial pulse. Is this lady sick or not sick? Bet you already caught it. Absolutely sick. She's unconscious, and there's a severe mechanism of injury. Okay, let's try this lady. She got in a cat fight in Whiskey Pete's. You're told that she got punched by another woman, and when you find her, she's sitting upright in a stool. She's alert and oriented. Her skin is warm, pink, and dry. She tells you she has a headache. Scale of 10, about an 8. There's no evidence of respiratory distress, and her radial pulse is strong and regular. Is she sick or not sick? Bet you did what I did. You focused on that headache. Punch in the head and a scale of 8 pain. I'd worry about her, but the bottom line is, per sick, not sick, she's not sick. She's alert, she's oriented, her skin is warm, pink, and dry, no evidence of respiratory distress, and she's got good perfusion. Yeah, I'm going to focus on that headache a little bit. I'm going to call her not sick, probably going to administer oxygen, put her on a backboard, and start moving her towards BLS care. But the bottom line is, per sick, not sick, right now, she is not sick. All right, try this one based just on what you see and no further information. This patient is not sick. She's sitting upright comfortably. She's got good color. She's smiling. She's engaging with the rescuers, and there's no visual appearance of any respiratory distress. What you do for this patient is finish your assessment, make sure she's splinted and bandaged properly, and you're going to reassess. Let's give you one without any specific photograph to go with it, just some information. Here you've got a skier who's going at a high rate of speed and landed chest first in the snow about an hour ago. He got up and kept skiing, but now suddenly he's slumped down sitting in the snow. As you approach the scene, you see no evidence of respiratory distress. He's pale and wet, and his color improves when he lies down. As you approach, he struggles to sit up, and you notice that his color gets worse. When he sits up, he tells you he's dizzy, and he feels better lying down. His chief complaint is that his gut hurt, and he can't see right. He describes it as visual dimming. Is he sick or not sick? Absolutely sick. Mechanism of injury: high speed, injury onto snow. His body position's inappropriate. He's sitting slump. His skin signs are pale and wet, and he's evidencing postural drop by that color getting worse whenever he sits up, and by his dizziness. That visual dimming is an indicator of syncope. You can even use sick or not sick if you have more than one patient. Let's look at these two. This patient is a 40-year-old male who collided with a lift tower. He's got a femur fracture. It's open with just a little bleeding. There's no evidence of respiratory distress. Skin is warm, pink, and dry. He's alert and oriented, but in a great deal of pain. Patient 2 witnessed this collision. She presents to you as pale and says she's having chest pains, which she describes as a level 8. She denies ever having had a heart attack, says she gets chest pains and takes nitroglycerin. She hasn't taken it yet. As you expose the injury on the first patient, she's watching and becomes syncopal. Based on sick, not sick, how would you classify each patient, and which one would you initially prioritize? They're both sick. The first one because of the mechanism of injury. The second one, because she presents as pale and chest pains, there's that nature of illness, possible heart attack. She becomes syncopal. You're going to classify her as sick as well. You're going to have her take her nitroglycerin. And if those symptoms resolve, her color improves, she's sitting comfortably or standing comfortably, and she's no longer in pain, you can reclassify her as not sick. But if her signs and symptoms don't change, don't become better, then I'm going to classify her as sick. And I think she's going to be my priority patient. So you classify a patient as sick. What are you going to do? Basically, you classify this patient as sick and notify base. You're going to call for equipment that you know you're probably going to need, like oxygen, backboard, additional personnel. You're going to complete a rapid assessment, but you're not going to delay transport. You're going to go with the signs and symptoms. You're not going to worry about getting a diagnosis on this patient. You're going to call in your short with at least 2 sets of vitals, request ALS, and you're going to move. And be sure you document well. Classify them as not sick. What are you going to do? Call for base and say, I'm on scene with a not sick patient. You're going to complete your assessment, call in your short with 1 or 2 sets of vitals, and treat as appropriate per OEC protocol. You're also going to document, and this patient probably isn't going to need more than BLS transport or maybe even go home in their own vehicle. But remember, as long as that patient is in your care, you need to reassess continually. See, this really isn't hard. You can determine sick, not sick in well under 60 seconds. You can move it quickly and efficiently, and you can get a short to base with critical information in less than a minute. Super. Our next step is to get you out on the hill and try this in some simulated scenarios. We hope that you found this to be helpful and valuable and something great to add to your toolkit. Thank you so much for your time and consideration. Thanks for being responsible for your learning, but above all, thanks for being part of Snoqualmie Pass Ski Patrols.